Hello, good evening, everyone. Welcome to my conferences. Welcome to the webinar tonight. And this is Wednesday evening, and I'm glad that you are here. And I hope that you have some questions because, as you know, we are back with some more success stories. There are three success stories that our presenter will discuss tonight, and I'm very happy to introduce you to Rita Matias. You can see her right here. Hi, Rita. Thank you so much for joining us tonight. This is your first webinar with my IVF Answers, so I'm glad that you said yes and will present, of course, tonight. As you know, the topic is advanced maternal age, and of course, Rita will talk about that, and of course, she will present the three cases she has prepared. And Rita is a nurse at Ferticentro, Coimbra in Portugal. So we are connected tonight with Portugal. I'm always happy to hear such amazing places for sure. And how are you, Rita? Welcome to my IVF Answers. How are you tonight?
Hi, Caroline. I'm fine, thank you.
Thank you so much.
Thanks so much for the invitation. I'm glad
Thank
to
you.
be here and to talk with you.
It's a pleasure to have you here for sure. And remember that this is going to be recorded, of course, so you will be able to watch this. It will be available tomorrow. And now I believe we can go ahead with our presentation. As I mentioned, it's going to be definitely an interesting presentation. And afterwards, there will be time for your questions. So as always, do it. Ask anything that you would like to know. And I know Rita has been very busy today at the clinic, and I'm sure she still will be happy to answer some of your questions. So let's get going with the presentation. Okay, Rita?
Sure.
Thank you so much.
Thank you, Caroline. So as Caroline mentioned, my name is Rita, and I'm a nurse at Ferticentro Clinic in Portugal. And I've been working with human reproduction since 2014. So today I'm going to talk to you and to make a presentation about pregnancy cases in women that have 30 years old or more, and talk to you a little bit and show you a few cases that we had, real cases that we had here at the clinic, successful ones. And so just to give you a little bit of a context before I start talking about those specific cases. So pregnancy after 38 years old is a tendency worldwide. Women are starting to have children later and in their lives. And for instance, this case, this news from the New York Times that says that 100,000 Americans give birth in their 40s each year. So women are having children later in their lives. They are postponing their pregnancies and conceiving. And this is a concern in the Western societies. And why is that? They are having children later in their lives, and there are a few reasons that are related to that. For example, like the education level. So people nowadays they have a higher level of education, and sometimes that it is difficult, and for women it is difficult to have a balance between their studies or their jobs and maternity. And also for economic reasons, economic uncertainty, because couples or women don't have a stable job. Sometimes they have unstable or temporary jobs. And also values regarding parenthood are changing. So sometimes people want to wait a little bit more to try to have more stability. Maybe they want to give their children better conditions than they had themselves when they were kids. And these are a few reasons that lead to women having children later than it used to be years ago. Okay. And why is this a problem? So this is a concern because we all know, and studies show that with age, the rate of oocyte aneuploidy increases, and also because of that, with age, the quality of the eggs diminishes, and because of that, also the quality of the embryos when we do fertility treatments. The quality of the eggs will also affect the quality of the embryos, and so the risks of trisomy, miscarriage, and even the obstetric risk increase. And on the other hand, the pregnancy and live birth rate decreases. Okay. Regarding the obstetric risk, we have situations like emergency cesarean, preterm birth, low birth weight, high blood pressure or preeclampsia, gestational diabetes, and stillbirth. These are some situations of obstetric risk that happen more often in women these ages than in younger women. But this is the reality nowadays. This is what is happening in a generic way all over the world. And we all must deal with the reality, and we all must adapt. I mean, we professionals that work in human reproduction and the clinics all over the world, we must adapt and try to give our patients the best advice given this reality. So what can we do? We must evaluate every patient individually. There aren't two people that are the same, so everyone's different, all patients are different, and we must evaluate every patient individually. We have to discuss the risks that are presented given the situations, so that they can take informed decisions with our help, and also avoid multiple pregnancies, since multiple pregnancies are also associated with higher risks, okay, for the mother and the baby. And so we only move on when we see and when we think that it is safe for both and mother and future baby to proceed with the treatment. In some challenging cases, such as patients with viral infections or with rare diseases and transplantation, we can work together with other medical teams from other specialties, and having their agreeing with the patient, with the treatment, sorry, and to collaborate with these teams in order to do things in a safe manner and the best way for the patients. Okay. In patients that come from abroad, or they're doing the treatment abroad, or they're starting the treatment over there, and then they will only come in a, let's say, in a final phase of the treatment, it is very important that we stay in touch, that we have a close dialogue with those medical teams, so that everything goes as expected and everything goes well. So if you're over 38 and you want to get pregnant, let's start talking about it and what can we do in, let's make things practical and and talk about what can we really do in our practice to achieve that. So we have to do the pregnancy risk assessment. Can we cope with it? Is it possible and safe to have a pregnancy? We have to assess the ovarian reserve and check if it is viable to do the treatment with the patient's own eggs, or if we should go for an egg donation instead, if PGTA is the solution for the case, what are the implantation conditions, if we have a uterine integrity, and check for the uterine receptivity. And one of the most important things in these ages is to check for the ovarian reserve. So we know that the ovarian reserve, well, it always diminishes since we women are, since we are kids and since our puberty, it always starts to diminish and to go down, but mostly from 35 years old onwards, it decreases in a more important manner. So it is very important to assess the ovarian reserve to see if it is viable to do the treatment with the patient's own eggs. And between all the hormones that we can check, there are two that are very important, and they are the FSH and the AMH. So the FSH, with the depletion of the ovarian reserve, it's the value of the AMH starts to increase, and the AMH, which is a hormone that is produced by our follicles that we have in our ovarian reserve, because the ovarian reserve starts to diminish, the AMH also starts to diminish. So a higher FSH level and a low AMH level are sign of a bad prognosis. Okay, so for a normal prognosis, what we want is to have an FSH that is under 15 and an AMH that is superior than 0.5. Okay, but the FSH, the ideal would be less than 8, even if we still do some treatments if the AMH is below 15, but the ideal would be less than 8. So after assessing the FSH and the AMH, we will see if it is viable to do the treatment with the patient's own eggs or not. So we have options like the pre-genetic testing for aneuploidies. The patient can do an ovarian stimulation followed by the fertilization and creating the embryos, and then do the genetic testing of these of each embryo, of these embryos, to check for aneuploidies, for abnormal genetic embryos. Another option is the egg banking, or fertility preservation, as we often hear it calling also egg banking or fertility preservation, or oocyte preservation. So just regarding the PGT, the pregenetic testing for aneuploidies, if you check on this, if you check here, in gray we have the embryos that are the implantation rates of embryos that have been tested with the PGT. And in, I don't know what color you see, but like in sort of orange, we have the embryos that haven't been tested, and the implantation rates are higher for embryos that have been tested. And even if with age the rate decreases a little bit, it decreases in sort of a steady way, in opposite with the ones that are not tested, that the implantation rates are lower, and with age the implantation rates decrease in a more accentuated way. So that makes that the delivery rates per transfer are also higher with in embryos that have been have been tested genetically, and the miscarriage rates are also lower. So with PGT, we can select the embryos. It doesn't make the treatment results better. It doesn't. It only selects the embryos before we transfer them, and that makes us have better results after the transfer, because we are already transferring embryos that have been tested and that we know that they're normal and healthy genetically speaking. So it's a pre-selection, so that it's a lot of help. So we put aside the embryos that are not genetically normal and healthy. We also have egg donation, which usually is the last resource, but it's also the most reliable one. So egg donation, it's a treatment that gives us great results. Here you can see that the differences between transfer from embryos that have been made with donor and non-donor. So the rates of success are much higher, with around 60%, 50 to 60% as age increases. But the success rates are much higher with the embryos that have been made through egg donation than the other ones with non-donor eggs. So here in Portugal, we do the egg donation. We only have non-anonymous donors. So we do the treatment with non-anonymous donors. We can respect the child's right to know to have access to their origins, and we do it in a transparent, well controlled and properly counseled way. It should be done also in an affordable and accessible way, without waiting lists, which is what we usually try to do here in Ferticentro. So now I wanted to talk to you about the 3 cases that we had here at the clinic, to show you in our practice what we really do, and I think you'll understand better how we we do things here. So in this case, we had a patient that was 41 years old. She was single. She had no male partner, with a normal BMI, and she had no previous pregnancies. She only did in 2020 a fertility preservation, and 2021 she did an IVF with sperm donation, and the result was negative. Between 2020 and 2021, she also did 3 intrauterine insemination with sperm donor, but they all the result was negative for all 3. So we, as I explained, we assessed the fertility, the ovarian reserve. So she had a good AMH. She had 1.8 and an FSH, well, slightly above the ideal, but still 8.95, and the karyotype was normal. So what we proposed to this patient was to do an IVF with sperm donor, but with the pre-implantation genetic testing for aneuploidies. So we did a stimulation with Menopur 300 units and orgalutran, and trigger with both Ovitrel and Decapeptyl, a double trigger. And in the egg retrieval, we obtained 12 mature eggs that we fertilized with the sperm donor. And we had 7 blastocysts that were all, we done the biopsy for all of them, the PGT. And we had the PGT result. We had 2 euploid blastocysts, so 2 genetically normal blastocysts, and we did a transfer of one of them. It was a blastocyst of type B that had been frozen in day 5. And the transfer was made on the 2nd July, and the HCG came positive. So we have, the patient is now pregnant, and she's 23 weeks pregnant by now. So on the second case, we had a couple. So she was 42 years old with a regular BMI and no previous pregnancies. She had surgery, so she had an ovary that was, the right ovary that was had been partially removed. And he was 43 years old, no kids. Both of them didn't have any history, medical history, personal or in the family. They didn't have any issues or diseases in particular. They already have had done an ovarian stimulation in another clinic, and they only had 1 egg that didn't have a good quality. So on this patient, we checked the AMH, which was quite low, 0.1, and the FSH 4.29. So what we did was to explain and present 2 options to the patient. So we've explained the success rates of both IVF with PGT-A and egg donation. And the couple preferred to go with the egg donation. So what we did was, because the transfer hasn't been done in the same right away. I mean, we had the time to do a mock cycle, which is like a test in the natural cycle of the patient. We have tested the endometrium response. So we used ovulation tests and ultrasound control, and also a blood test to check for the progesterone levels, and check how the cycle of the patient was, and if we had a good endometrium to transfer the embryos afterwards. So we used the eggs of an egg donor that was 24 years old, and from 10 mature oocytes, from 10 mature eggs, we have done the fertilization with the male sperm, and we have obtained 3 blastocysts. We transferred 1 blastocyst of type A on the 10th November. This is a case that is a very, very recent one, and the patient is now pregnant. She's only at 4 weeks now, 4 weeks pregnancy, but well, everything seems going fine with the pregnancy. And I wanted to show you this last case, which is an older one. We had a couple. She was 39 years old with a regular, normal BMI. She had no previous pregnancies, and he was 43 years old with no kids. The only thing that we detected with the spermogram is that he had a teratozoospermia, but nothing very important or problematic for the treatment. And they were trying to conceive since 2009, so for a long period of time already. And in 2016, they had done an ovarian stimulation where they had and they have done 8 embryo transfers, and all of them the results were negative. So we've assessed the ovarian reserve with AMH, which was good, 2.47, and the FSH level was 5.3. Both karyotypes were normal, and she also had done blood tests to exclude thrombophilia, which is also associated sometimes with problems of implantation of the embryo or even miscarriage, and it was all negative. So they preferred to do an IVF. So we did an IVF, an ovarian stimulation with menopur 150 and cetrotide, and we had on the day of the egg retrieval, we had 8 mature eggs that were fertilized with the male sperm, and we obtained 3 blastocysts that were all in all of them we have done the PGT, but sadly all 3 embryos were aneuploid, so none of them had conditions to be transferred. So what we did after that is that we proposed the couple the option of the egg donation treatment, and they agreed. They decided to go for an egg donation treatment, and we have done we have fertilized 11 mature eggs of a 31-year-old egg donor, and we had 5 blastocysts, which is a very good result. And we transferred two blastocysts on that same cycle, and we had a pregnancy test that was positive, and they had a baby girl in November 2017. So it's been a while now. In 2019, so they had 5 blastocysts, and they transferred 2. She got pregnant, but only a baby girl was born. Sometimes, well, this happens quite often. So with the remaining embryos that they had frozen, they have done a new transfer in 2019 and had another healthy child. Which is great. They could have chosen to do another option, another IVF with PGT, but they've chosen to go with the egg donation, and we're very happy that we had this outcome. So this is our team. There are a few people that are missing. The team is bigger now. We have grown quite a bit. So thank you very much for listening to me, and I can answer your questions now. So,
wonderful. Thank you so much. Thank you so much indeed, Rita, for that presentation, for the cases that you have presented. It's always amazing for me to see, of course, different decisions, different approaches as well. But of course, the outcome is a healthy baby, which is great, of course. And this is what we are all here for as well, of course. So thank you so much. And now it's time for your questions. So go ahead, type those in, and let's have a look. We have a few questions here. And let me just show you the first one. Do you look at E2 estradiol, estrogen level at starting the cycle?
In a treatment with the ONADs?
Yeah, I think so.
We usually ask for lots of we check for other hormones. I've mentioned FSH and AMH as the most important to assess the ovarian reserve, the fertility reserve. But yes, we also ask for the estradiol levels, estradiol, prolactin, even thyroid hormones that are very important also. So yes, there are others that I didn't mention. The estradiol is included in that list. Yes, we do ask for estradiol levels in the beginning of the cycle. Usually on day 2 or day 3 of the cycle, we ask for the blood work, and yes, estradiol is included.
All right. Thank you so much for the clarification, and thank you for your question. And if you can have a look at this, so did you do karyotype for semen donation or DNA fragmentation test for semen sample?
In case no one did.
That's why I must, yeah. So do you do this is like a normal thing to do? Do you check
for
DNA?
Semen donation or DNA?
Sperm fragmentation, yeah.
I'm sorry, I don't quite understand the question.
So I think we can make it just simpler. So is it like, do you offer, do you do DNA fragmentation tests, for example, in the cases that you discussed? Was this also suggested? Is it something that you also perform for males?
Yes, of course. We also do that type of exam for the DNA fragmentation. Regarding the karyotype for semen donation, in a treatment with the patient's own eggs and a semen donation, is that it?
Possibly, it's hard for me to say, but of course, let's assume, yeah. So we can let's assume that. And of course, if you would like, go ahead to type this, of course, if you want to clarify.
So all of our donors, sperm or egg donors, do the karyotype. So we test for the karyotype if it's normal or not. So when we use sperm or egg donation, either one or the other, we always ask the other member of the couple that we are using their gametes to also do the karyotype, to test for the karyotype. Yes.
Okay.
I don't
So
know
it's
if I
something
answered the question. Sorry, but
yes, exactly. Of course, if you would like to have any follow-ups, just go ahead, type this in. But I think that, it's also important, right? So if there is a sperm donor, there's no need because you already do it. Yeah, you always do it when it comes to karyotype. You always check it in every
yes.
sperm donor, right? Okay. And thank you so much. And sorry, one more time regarding the DNA fragmentation tests for for male partner, of course. Is it always performed as well?
It is not always performed. There are lots of cases where it's not indicated, but in the most in cases with an important male factor, it is offered. It is proposed quite often. Yes.
Okay, thank you again for the clarification, and I hope that was also useful for you. And this is how, this is what you wanted. As I mentioned, if you want to add something, go ahead, type this in. Okay, let's have a look. Okay, there is another question. What are the rates for single versus double embryo transfer in patients over 40? Is single embryo transfer always recommended?
They always love to ask about the rates, right? So
It's true.
A single embryo transfer is a single embryo transfer always recommended? Well, most of the times, yes. We always have a tendency to suggest, to propose transferring a single embryo at the time, and that's what the guidelines, the European, and it's been made all over the world. The guidelines tell us to prefer transferring only one embryo at a time. So that's what most of the clinics tend to do, and most of the professionals, we always prefer, and we always advise to transfer of a single embryo. So that's what is made most of the times, but that doesn't mean that that in some cases we can do a double embryo transfer if the patient wants to, or it depends. As I said, each case is different and each patient is different. There are some situations where it's contraindicated. We really don't advise the patient to do a double embryo transfer. Maybe the uterus doesn't not have the conditions to do so, or even there are lots of situations that can be a contraindication to transfer two or more embryos. Well, more than two. We don't do that in Ferticentro, at least, and in Portugal I don't think that the clinics do that. So that's it. Most of the times we advise to do a single embryo transfer, but yes, we can do a double embryo transfer, no problem, if there aren't any contraindications or any clinical situation that tells us to do otherwise.
Of course.
Regarding the rates between single and double embryo transfer in patients over 40, It depends if the treatment has been made with their own eggs or not, or with sperm donation or not. What I can say is that the rates, they don't double because you transfer two embryos. The rates do not double, which most I think lots of patients think that that is the case, but it is not the case. So you have to think and about the situation, and if it's what is more convenient and what is the right thing to do, if it's to really transfer two embryos. It depends. It is very hard to talk in a generic way like this.
Of course, definitely.
Because sometimes let's say that you've done a treatment with your own eggs. You only had two embryos. So that means you can do one transfer or two tops. If you choose to transfer them at the same time, if you choose to do an embryo transfer, only one embryo transfer and you transfer both embryos, well, the chances don't double, the rates don't double, and if you have a negative outcome, you've lost both your embryos at once, at only one time, and maybe you could have done two embryo transfers, and well, we don't know, but maybe you had a second chance to get pregnant and you wasted it only in one time. So it really depends.
Of course, this is something that you need to look individually on the couple, yes, and of course the situation. I understand, of course, completely. And thank you for explaining, because I think that many times it's omitted, yes, that it's not always the case, yes, that two is always better. It's not the case here.
No,
sure, right?
Not at all.
Exactly. Thank you so much for bringing this then, of course. And let's have a look. And thank you for the question. Definitely good question.
Yeah.
And let's have a look. Okay. This is also something that comes up a lot. Do you always transfer day 5 blastocyst?
Most of the times, yes. If we have the conditions to do so, yes, we tend to do more transfers. We tend to do the culture until the stage of blastocyst. But we also have lots of patients that got pregnant with the day 3 embryo transfer in day 3 embryos. So we have both, but right now, and it's been a while already, yes, if we can, we usually try to do the culture until the stage of blastocyst. Blastocyst stage can be attained at day 5 or day 6. Okay.
Of course. All right. Thank you so much for the question indeed as well. And let's have a look right here. Does genetic testing really increase pregnancy rate in older women?
Well, yes, because let's say that we do an ovarian stimulation and we have 8 eggs. We do the fertilization of those 8 eggs. And we have 4 embryos, okay, 5 embryos, let's say, and we do the PGT on those 5 embryos. We have the PGT outcome, and 2 of those 5 embryos are genetically healthy, normal, and there are 3 of them that are aneuploid, so they have abnormalities. We are only going to transfer those 2, and the other 3 will be discarded. So if haven't we done the PGT, we would be transferring at least 3 embryos that weren't healthy, genetically healthy, and we wouldn't have a good outcome, or we would have negative results, or maybe miscarriages, and maybe would the patients would over they would have given up on the treatment, and maybe didn't even get to transfer those two ones that were finally were healthy. So because we with PGT we are already transferring the embryos that are healthy and that are going to give us the best success rates and the best chances. So yes, the pregnancy rates will increase because we are already selecting we are already putting aside the bad embryos. We are only going to transfer the ones that are healthy. So yes, the pregnancy rates will be better than without the PGT.
Okay, thank you for the question, and thank you for your explanation to that one as well. And it's in regards to the case, why did you decided to do double trigger?
Well, it it depends on the cases also. The trigger is always something that depends on each case. On this case, we've done the double trigger to. There are some studies that show us that it has good results with the maturity of the eggs. But the trigger really depends on the goal of the treatment, if we are going to do the transfer on the same cycle of the stimulation or not. Sometimes we use only Ovitrel, sometimes we use only Decapeptyl when we aren't going to do the transfer on the same cycle. So it really depends. There aren't two cases that are equal. So
of course,
I know that well, sometimes it helps us to relate to other cases and to try to see where we fit in, so to speak. But we always have differences between.
It's never black or white, right? When it comes to that,
it's not maths. It's not 2 + 2 = 4. So yeah.
The correct protocol has to be, of course, again,
yes,
I guess
the protocol is always tailored to the patient.
Exactly.
Or to the couple, or...
Of course. Thank you so much indeed for the question, and let's have a look. Might be our final question for tonight, okay? So if you have more, this is your final call. Go ahead, type those in. And this is a question from Penny. I am 44, having irregular periods, 28-day cycle lasting 3 days. Is it possible to use my own eggs still, or should I go straight to donor eggs?
Okay. Penny, so we, as I showed in the previous slides, we have the fact that your period is still regular, your cycle is regular. It doesn't mean that the ovarian reserve is good. Okay, so we would have to check. You have to do a blood test. Check for the FSH levels, AMH levels, and even other hormones, as I've mentioned before. And we have to assess the ovarian reserve in order to check and to see to be able to decide if it is viable to use your own eggs, because the fact that the cycle is still regular is not it doesn't make, so we can predict your ovarian reserve through that. So it's not really related. Okay.
Okay, understood. And of course, I always want to add that remember that this is, of course, a place where you can ask questions. But if you wish to get some more details, as you can imagine, the doctors, the nurses, they would definitely need some more details from you in order to properly assess and offer some sort of solution in your situation, right? So remember, you can always get in touch with Rita and her team at Ferticentro, and I am sure they will be more than happy to help you out with any more questions that you might have. As I've mentioned, it looks like that was our final question. So thank you so much, everyone, for joining us, for your questions, for taking part in it, of course, and I believe that was helpful for you. Rita, thank you for joining us tonight as well. It's great to have you here. This is your first time. I hope we will be able to simply repeat that. And before we finish, anything you would like to add?
Well, thank you so much for inviting me once again, and we we're available here in Ferticentro. If you have any more questions, you can always get in touch with us and contact through our website, or I'm sure you maybe Caroline will leave you the contacts, but you can, you have access to all the information through our website, and you can get our contacts. And if you have any more questions, I'll gladly answer to them. So that's it.
Thank you so much indeed. And yes, so once we finish, you will be redirected to the website when it comes to Ferticentro and Rita. So you can also use this link and simply get in touch. There is a contact button right there. And again, thank you so much, everyone. As you know, it has been recorded, so you will have a chance to have a look at this tomorrow on myivfanswers.com on our YouTube channel. If you subscribe, you will be notified that it has been added. So I can only encourage you to do that. And as you know, there is one more webinar tomorrow at 7 p.m. UK time. We will talk more about low ovarian reserve this time and more success stories. So I hope you will be able to join us as well. Thank you, everyone. Have a nice evening, and Rita, till our next event, and also have a relaxing evening. You deserve it after such a long day, right? So thanks so much indeed.
Thank you, Caroline.
Bye.
Bye-bye.